All right, thank you so much for the invitation to present here. Tara and I will be talking about the impact of COVID-19 on cancer care delivery in Africa. And these are the results of a survey we just conducted between June and August to look at the impact of COVID-19 on cancer care in the region. So we're going to split this into two. I'm going to give you a little bit of introduction methods, and Tara is going to talk about most of the results and some of the discussion points that we wanted to highlight from our study. Before we go ahead, I wanted to acknowledge that this has been a huge multi-collaborative effort. And I want to thank especially these group of people from different countries in Europe and the US and Africa for their input and advice and participation in the study. And it's definitely been a huge success having multiple different people on board. So just a little bit of an overview of the distribution of COVID-19 new cases globally. And so we do know that the number of cases are increasing globally, and this shows sort of which regions are contributing hugely to the number of new cases. And so if you've been watching the news, you know, a lot of the cases are coming from the US and then also from Europe. But if you look closely, you can see sort of the green areas, which highlights the uptick of new cases in Africa, actually. And so I just wanted to highlight this, that new cases are going up. It is still a very relevant pandemic in Africa. And if anything at all, unlike the low cases we had initially at the beginning of the pandemic, it looks like there's been an uptick of cases. And this bar is to just highlight when you look at our numbers, noting that this period is when we actually conducted our study. And so, as you may be aware, the number of new cases now is over 46 million, and more than 1.2 million deaths have been recorded due to the pandemic. So COVID-19 has disrupted cancer care delivery globally, and this is very well known now about its impact on NCD care. And so over here on the A side is where we are, where, you know, resources dedicated to controlling the pandemic have really been, have weighed heavily and disrupted cancer care. And so there's less of an emphasis on continuity of cancer care now. And the goal is to shift to a more balanced view where we're able to effectively control the pandemic, but then also can manage to continue care for our cancer patients and avoid adverse effects later on. But then I think I should point out that Africa, on top of the pandemic, has been facing a cancer care crisis for a while now. And this is just a graph to illustrate sort of what the case fatality has been for the Afro region for cancer. And so the blue bars represent incidence and the red bars represent mortality. And so when you look at Europe and the Americas, the red bar is only a fraction of the blue bar. And so a lot of the patients, vast majority of patients who are diagnosed with cancer do not die from their disease. However, when you look at the Afro region, these curves are almost overlapping. And so a huge proportion of patients who are diagnosed, which is the blue bar here, will end up dying from cancer. And so there's the increased burden of cancer mortality at baseline in Africa. There's also studies to show that the cancer workload in terms of the number of oncologists available is actually disproportionately lower in Africa. And so you have several significantly higher percentage of oncologists seeing more than 500 consults a year. And so what we have here with a pandemic is really a crisis within a crisis. And you know, the question is, what is the impact of COVID-19 going to have on an already constrained resource setting for cancer care? So we conducted the study to answer a few specific aims. We wanted to look at the scope of COVID-19 and cancer care specific response strategies employed by African countries. We wanted to examine the distribution and clinical outcomes in cancer patients who've been diagnosed with COVID-19. And then we wanted to explore myths and misconceptions about the virus that physicians are confronting on the continent. If you've heard me speak before, we had an aim for which was to look at the impact on the well-being of providers. We don't have the results of these yet, but we hope to present that at a later date. I think we have some interesting results there, but we won't talk about that today. So this was a cross-sectional web-based survey. We anticipated 150 participants, and as you would see, we enrolled much less. The inclusion criteria was really any cancer care provider in Africa, and we recruited using the AORIC listserv. So this is the African Organization for Research and Training in Cancer listserv that has about 40 African countries represented on there. And then we used snowball sampling methodology, which allowed people to complete the survey, but then also share the link on their social media platforms. Our data analysis was really mostly descriptive statistics, and I'm going to go ahead and present some of our results now. And so this is the flow diagram of our study participants. So all participants who initiated the survey, the size of that population was 122. So we had 122 who actually initiated the survey, meaning they picked a preferred language in which they wanted to answer the survey. But unfortunately, 16 of those people did not proceed to the consent page. And it's unclear to us why, whether it was related to connectivity issues or other issues. We are unable to tell. So 106 consented, but then out of those, 27 did not provide any survey data. And so the results that we're going to present here today are really based on 79 participants who either provided full or partial data that we've included in our analysis. And these 79 participants represent 19 countries in Africa. As you can tell from the color coding here, areas where we had more than 10 respondents per country were Nigeria and Zambia. Botswana and Zimbabwe actually contributed a lot of participants as well to the study. Most other areas had 1 or 2 participants per country. So demographic and practice characteristics. So most of the participants were slightly more than half were female. We had mostly young patients, 31 to 50 were youngish patients. The survey was available in English, Portuguese, and French, although most people completed the survey in English. And over here, you can sort of see sort of the distribution. There's a lot of heterogeneity in who completed the form, but most people were MDs, and most practice sizes were less than 3,000 patients, oncology, cancer patients seen per year. So COVID-19 general response strategies was sort of the same as we've seen in other countries. So education, social distancing, hand hygiene, mask mandate, and national and regional lockdown. So I wouldn't really delve into that, but majority of countries actually employed these standard non-pharmacologic interventions for COVID-19 control. Specifically looking at oncology response strategies, there were similarities in terms of provider-facing strategies and patient-facing strategies. Again, social distancing, mask mandates, and temperature screening for all patients. Those were similar for providers as well, having temperature screening, social distancing, and mask mandates. I wanted to point out that what was really interesting is that you're starting to see some innovation in terms of provider-facing strategies. And so some countries like Rwanda were using drone delivery services, either for obtaining sample collection or delivering cancer medications, which is great to see. There were also countries that were using courier services actually to deliver medications to the home of patients where feasible. And then there's also the use of telemedicine was actually more common than we expected in the region. I'm going to pass over now to Tara.
Thank you, Yehoda. So this slide highlights how COVID mitigation strategies have affected cancer therapy delivery. Many cancer centers implemented several therapy modifications shown on this slide. And as you can see, many of these modifications centered around delaying visits or reducing the number of visits. For example, nearly 70% reported a postponement of routine surveillance visits, and 30% reported delaying new patient visits. There were modifications in all modalities of cancer treatment as well, including chemotherapy, radiotherapy, surgery, and palliative care. Again, a majority of these modifications were delays. For example, delay in palliative chemotherapy or non-emergent palliative radiotherapy, delaying surgery for patients with low risk of progression, or delaying inpatient hospice referrals. Another modification reported was an increase in the use of hypofractionated radiotherapy to reduce the overall number of visits. Next slide, please. So, although almost all cancer centers remained open, 3/4 of respondents reported their centers had reductions in patient volumes, primarily due to fear of exposure, travel restrictions that were implemented during lockdowns, and facility-led interventions to reduce the number of visits, as discussed on the last slide. Next slide, please. Oh, sorry. In regards to resource shortages, staff shortages at cancer centers were reported by nearly 60%. The two top reasons for staff shortages were isolation and quarantine, and fear of contracting the virus. 3/4 reported a shortage of PPE. Most reported they had access to surgical masks and gowns. However, less than half had access to other PPE, such as goggles, face shields, gowns, and N95 masks. 30% reported only access to cloth masks, and 11% were obligated to provide their own PPE. Other resource shortages reported during the pandemic were cancer medications and analgesics shortages. This slide captures clinician perspectives on the number of COVID-19 cases and deaths in patients with cancer at their institutions. Most reported 25 or fewer confirmed COVID-19 cases and 5 or fewer deaths among patients with cancer. Otherwise, many reported no known COVID cases or felt like they were unable to quantify. However, it is important to mention that 10 institutions had multiple respondents who provided data, and in some of these cases, there were discrepancies in the individual institutional level data. The most common COVID-19 related misinformation that oncology providers confronted amongst their patients were that Africans were less susceptible to the virus and that COVID-19 is less infectious in the African heat. Many also reported that the utilization of traditional remedies and the belief that strong faith can ward off the virus. Potentially harmful beliefs were that ingesting alcohol or bleach could be beneficial. Thus, we have seen that African countries have implemented common mitigation and suppression strategies listed here that are observed globally. However, it has been reported that some countries have employed more severe measures, such as state of emergency declarations and military enforced national lockdowns. Our data reports few numbers of COVID-19 cases overall amongst patients with cancer, and even fewer deaths, which may reflect successful implementation of these strategies. But experts are still divided over whether the low number of cases and deaths reflects successful control and environmental factors versus incomplete case enumeration. Regardless of the reasons, our data highlights the disruptions in cancer care delivery for patients on the continent, which already has some of the highest case fatality rates due to cancer globally. The frequency of delays and disruptions of all modalities of treatment are concerning for long-term adverse impact on disease-free and overall survival among cancer patients. In addition, the pandemic has worsened resource shortages. PPE shortages are not unique to Africa during this pandemic, as supply chains have been stressed globally. However, up to a third of participants, a critical workforce, were without the most basic access to PPE, gloves, and surgical masks. The pandemic has also caused a worsening shortage in oncology workforce. Not previously reported is how the role of fear of virus transmission is contributing to staff shortages, especially where PPE shortages are widely reported. However, the pandemic has presented opportunities for inspiring innovative solutions, such as utilization of drones that are tailored to the healthcare systems in Africa. This technology leapfrogging, although cost effectiveness is unknown, may serve as a blueprint for expanding care and preparing for future pandemics. Our study has several limitations. First, the anonymity of the study limited our ability to control for multiple responses. However, it was clearly stated in the instructions and consent that this was to be completed once per participant. Second, the small sample size, the disproportionate representation of countries, and the potential for selection bias by using professional society listservs limits the generalizability of our results to all African countries. However, our results are consistent with a recent publication from 54 cancer institutions, mainly from Northern Africa, recently published in JCO Global Oncology. Lastly, the discrepant institutional data that was already discussed suggests that staff do not have access to a centralized database of institutional data, and reports of COVID-19 cases may be estimates and anecdotal, thus limiting their reliability. In conclusion, this study shows that the direct effect of COVID-19 in patients with cancer in Africa may be low. However, there has been substantial disruptions in all modalities of cancer care, which may lead to indirect effects such as worsening cancer outcomes. As data continues to expand, there is an enormous capacity to learn from the successes, failures, and tailored innovative solutions to formulating effective policies that minimize harm to cancer patients and staff by this pandemic and future pandemics. We want to thank Aortic for their contributions, as well as all the study participants for taking time to take the survey during such a challenging time. Thank you very much for attending this session. Our contact information is on the slide, and Dr. Martei will be available after this recording for questions. Thank you very much.
Thank you.